So I want you to keep some things in mind when you're modifying the checklist, and we'll talk about those right now. The first general principle is around trying to keep the checklist brief. So I will tell you that we see checklists that grow, and the temptation is to grow the checklist to take care of the last 5 problems that happened in your operating room. And what I want to caution you is just to be careful with the length. Because if it gets too long, it won't be usable, and you won't be able to convince anybody that it doesn't take very much of their time to perform these important safety checks. So you need to be thinking about how long it is. So each section, you should shoot for a target time of about a minute or so. So that's how much time you have to use before people are going to start to get antsy that you're wasting too much time. Again, we'll talk about this later for rapid turnover cases, but it's a hard sell for a checklist that takes longer than the operation that you're about to do without modifying it significantly. And then finally, I talked about it a little bit, and that is to try and keep it on one page. If it spills over to the second page, there's obvious issues. One is that it's going to take too long to do, and that's a symptom that it's too long. And the other is that the second page can get lost, or that you have to copy it, or people have to flip it over and they don't flip it over. We know what happens when things go beyond a single page. So try and keep it to a page. So brief. Brief is important. When you're modifying the checklist and actually doing this work, we have a series of questions that we want you to ask yourself about every item on the checklist and whether you need it or not. And we want you to think about these things. So they're here in the 5 boxes, and then I have another slide that continues a little bit of this. So you need to ask yourself, is this a critical safety step that's at risk for being missed? And the reason we ask that is we don't want to waste ink. So if there's something on the checklist that you know for a fact is done 100% of the time in your hospital, pull it off. That's why the South Carolina checklist doesn't have the line on it asking if a pulse oximeter is on. We know that you always do that. It does not deserve the ink in the United States of America to waste it on pulse oximetry, and if there are other items like that in your hospital, pull them off. Is this a safety step that you might not notice if it's not done? This is where the checklist can be the most powerful. There are many things that we do in an operating room that you can look and tell whether you did them or not. If you are using an iodine-based prep on a patient or a tinted prep, you can look at the skin and tell that the prep is on. If you don't give the antibiotic to the patient, unless you ask if it was given, there is probably no way for the team to know that the antibiotic was given. So that's the contrast. The checklist probably doesn't need to be used if the step is done and you can see that you did it. You may not need the checklist to prompt it. Is this item discussed at a time when all relevant team members are present in the operating room? Now, I understand, and the checklist has been built to accommodate the fact that in many places, the surgeon, in particular, isn't there for the whole time. But if that's the case, then the surgeon's discussion shouldn't be held until the surgeon's there. Now, if you are in a hospital that the surgeon is there through the pre-op into the induction, through the induction into the operation itself, and we know that there are hospitals that are like that, you can make your checklist reflect that and move some of the discussions around because the whole team's there the whole time. Some of the things that are on the checklist are where they are in recognition of the fact that the surgeon in many places isn't there at the beginning of the operation. If that's not the case in your hospital, then your checklist can look different. Is whatever step that you're talking about adequately checked by other means? And if it is, like the pulse oximetry, you shouldn't waste the ink. And are we talking about something that we can actually do something about? So that's the reason why we want you to ask about hypothermia when you can still do something about it in the first column before the induction. That's why that step is there. If that step were to be moved to the place where the universal protocol is part of the timeout, and obviously it's too late, the drapes are up. Well, it's probably not too late, but you certainly don't want to be stuck in the position of putting boots on a patient underneath drapes if you can possibly avoid it. So you need to think about what you're prompting and when you're prompting it to make sure that you can actually do it. Is the checklist the best way to take care of the problem? And up here are some things that hospitals have considered. And there are very varying opinions about whether the checklist can be useful to your hospital with these items. People have talked about glycemic control and embedding something about glycemic control on your checklist. You absolutely can do that, but if you choose to do that, then what I would suggest you do is use the checklist as a prompt for a protocol that you have in place and lives in another place. That the checklist doesn't bear your protocol, but bears the prompt for the protocol. The same might be true of a fire risk assessment. Although we have seen hospitals incorporate a full fire risk assessment in their checklist, it might be a better idea to save room on the checklist to have a prompt about a fire assessment if you think that's a good way to take care of it, and then have the fire assessment itself held in a different place. Hair removal, using the checklist for hair removal actually is or to control the way hair is removed, is another one of those things that it's probably not the right way to take care of the problem. And you want to address how hair is removed from the surgical site before the checklist ever gets pulled out. Some hospitals who have had problems have prompted checking for pressure points. Now, this obviously also depends on your particular facility, the kind of operations that you do, what risks the patients are at for having problems for pressure points, but you need to think of all those things as you decide whether to add that kind of an item to your checklist or not. So, can the checklist carry a check for pressure points? Absolutely. If it works in your hospital and that's the right place to put it, then you should put it on your checklist. But you need to bear in mind that you need to think about how much ink you're using to put extra stuff on your checklist. And that the more items you add, the harder it is to use the checklist. Now here's a last question that I personally beg that you ask yourself. If you decide to pull something off, and this particularly goes for things like the introductions or the discussion elements, and that is change your frame. Don't think about everything in terms of will it help me, the circulating nurse. Will it help me, the surgeon? But change your frame to could it help somebody in the operating room. It may not help the surgeon at all to verbalize the operative plan, but it probably will help the surgical scrub tech, the scrub nurse, the circulating nurse, the anesthesiologist tremendously to have extra information about what the surgeon actually plans. So be careful about the frame that you take, particularly if you're pulling stuff off the South Carolina template.